Well, good evening, everybody, and welcome back to week 2 of the 21st annual mini medical school program. Again, my name is Dr. Richard Colgan. I'm a professor of family and community medicine at the University of Maryland School of Medicine. I'm also our department's vice chairman and executive director of this mini medical school program. We hope you enjoyed last week's sessions with Dr. Shannon Thierry and Dr. Matthew Lawrence, who shared information on routine health screenings and the most recent developments in battling the COVID-19 pandemic. A special welcome to those of you who are joining us for the first time this week. This evening, we'll be hearing from 2 doctors at the School of Medicine, Dr. Gloria Reeves and Dr. Dominic Williams. But before I introduce our first speaker for the evening, Ms. Lauren Robinson will share a few housekeeping items and reminders. Ms. Robinson?
Thank you, Dr. Colgan. Again, welcome to week 2 of the University of Maryland School of Medicine's 21st annual mini medical school. I will quickly go over a few housekeeping items and reminders. You should have already received the link to the electronic course materials. If not, I'll repost the link in the chat box later on this evening. In the week 2 folder, you will be able to access the bio for today's speakers, as well as a copy of their presentations. The shared drive also includes a special note from Dean Reese and Zoom tutorials. We will be uploading weekly faculty presentations. Please make sure to check the shared drive each week before a class. In addition, kindly remember to complete the individual course evaluations at the end of each presentation. We plan to insert today's survey link at the end of today's presentation, just like we did last week. And please be sure to use today's link to evaluate today's presentation. A reminder about attendance: graduation certificates of completion will only be given to students who attend 4 out of the 5 sessions. Please remember to log in each week. We only know if you're here if you sign in with the email address you registered with in Zoom. And please note that we will be taking questions at the end of each discussion. Our presenters will spend the last 5 to 10 minutes of their sessions taking questions. Please insert your questions in the chat box while the presentation is in session. Or if you prefer to ask your questions audibly, you can use one of the 3 methods: by phone, by computer, or by using the Zoom app on your tablet or iPhone. Thank you for your attention. And now Dr. Colgan will introduce our first speaker for the evening.
Thank you, Lauren. It's my great pleasure to introduce Dr. Gloria Reeves. Dr. Reeves is an associate professor in the Department of Psychiatry at the School of Medicine. She also serves as the vice chair of research in the department. She earned her medical degree here at the School of Medicine, and she has practiced in Baltimore for over 20 years. Dr. Reeves is an expert in child and adolescent psychiatry with specialized expertise in pediatric psychopharmacology and obesity-related health issues among individuals with serious mental illness. Her research interest centers around how to improve family-centered care around various mental health topics, and she's more recently been studying how to improve telehealth, virtual quality of care, and how to address psychological aspects of vaccine hesitancy since the start of the pandemic. Here to present on how to manage stress, anxiety, and depression, Dr. Gloria Reeves.
Well, thank you so much. I'm really delighted to join my colleagues today at the mini med school. I did my medical training at University of Maryland, so I feel like we already are a kindred spirit, have a connection already. So I'm a very informal person. Please call me Gloria. And I know that it's a little hard living in this virtual life we're in. And so I always offer, when I give a presentation, if you are interested in making it more interactive, you can certainly indulge me by keeping your camera on. And if your camera is on, I might invite you to share some comments over the course of the presentation. You're welcome to speak or not speak as you choose, and I promise I will not ask anybody anything difficult, but I think it's just more fun if we can interact a little bit. So I'm going to share my screen.
My finger didn't work. So, okay, so what I'll do right now is I'll send Ruby is here. Okay, I'll send Ruby is here.
Okay, and Lauren, you can see my screen okay? Thumbs up. Okay. So, so I'm going to be talking about managing stress, anxiety, and depression. So I know stress is a topic that's sort of universally familiar to all of us, especially as we're getting through the pandemic. So it can be a really challenging time. So I'm hoping what I can do is give you a framework for how to think about this as a health topic, and also some tips and strategies about how to identify when there's kind of more red flags for stress, and give you an idea about how treatment for anxiety and depression disorders are sort of organized. So our objectives today are we're going to talk about stress, consequences of stress, both from the positive and the negative end of things, as our way of kind of understanding the big picture. And I'll introduce some common symptoms or how depression and anxiety presents in most folks, and give you an idea, a little bit of an overview about treatment of those conditions. And then some tips and resources on the end. I know that our graduates from the mini med school program are folks in the community who are trusted voices for friends, family members, neighbors around health topics. So I want to make sure you're armed with good information that you can share with others in your networks. So first, I'm going to start out with just a framework to how to think about stress. And I wanted to start out by introducing the idea that the word stress can have both kind of a positive and a negative connotation to it. And I wonder if I can, if folks don't mind, if they would like to participate in the talk in a more interactive way. I'm just going to invite a few people at a time to unmute to participate, and I'm just going in order in my screen. And if you don't want to unmute, that's totally fine as well. But I see is it Gemsetta Galloway and Davis Dutch Graf? If you'd like to unmute, you're very welcome to. Our medical colleagues, thank you so much.
Am I producing an echo? This is Gemsetta.
I think you're fine. Oh, now I hear the echo. Oh, because you have your phone on as well. So we'll see. We can try this a couple of times. If it doesn't work, it's totally fine. But the reason I wanted to ask your input, and feel free to just type in the chat if that's easier, if anybody would like to participate. But when you think about stress as a word, I think maybe the echo let me see. Okay. So maybe we'll try revisiting the participating by voice. I think Ms. Robinson, I may have screwed us up by having people unmute. Maybe we'll try without first, and then we'll move to try to do it during the questions. Okay, there we go. Okay, so when we think about the word stress, I think about it two ways. So one, as a feeling word. So this is a word that gets used a lot these days, especially during the pandemic. And it describes kind of a feeling of being overwhelmed, feeling tense, having an emotional strain. But the flip side of that is the word stress can be used as an action word. And that could be meant to emphasize something or to add pressure, like I want to stress the importance of this information. And I wanted to give sort of a visual image of those because we often think of stress as 100% negative. So I want to think from a health perspective, what are some of the pros and cons of stress to think about in a more comprehensive way? Because we tend to think about stress as always negative and something we want to completely eliminate from our life. And from a health perspective, we want to try to help people have more of a balanced view about that. So when we think about stress as a verb, it becomes a little bit more powerful. So it's an action word to emphasize, to pressure, and to kind of focus our activities. So what are some examples of that? So some of the benefits of a stress signal are that when we have that internal feeling inside of feeling stressed, it can help us do some very positive things. So first and foremost, it focuses our attention on safety issues. So we know during the pandemic, when people were worried about catching COVID or other issues, it really helps us prioritize our safety and the safety of those around us. Stress can also help us accomplish important tasks and to do them well and do them carefully. So I have a 17-year-old who's very stressed right now because she has a big project due for her English class. And so that stress is the thing that kind of keeps her on her toes to make sure that she does the work carefully and that she completes things and kind of makes her deadline. So stress can help us organize. A stress signal can help us get organized and sort of have a sense of urgency and a priority to finish something. The other thing about stress is that sometimes when we're under a bit of stress, it's when we're the most creative, the most innovative. When you really are stuck and you have to come up with a solution to something, a lot of times you think about ideas that you haven't tried before. So a stress signal can sometimes lead to creativity. And oftentimes that kind of problem-solving mode doesn't just benefit ourselves, but it benefits others. So again, the word stress can have some positive impacts on behavior and our thought process. When does stress become a problem or a potential harm? So there's lots of examples. So it's sort of easier to think about it from the negative perspective. So stress can be harmful for health. First and foremost, when you have kind of a misfiring of when you should be afraid or fearful of something. So for example, I don't know if anybody else has this fear, but when I'm flying a plane, I have a terrible fear of heights. So I don't like to be up high and see that distance that I'm down, or if I'm in a tall building on the 13th floor, 14th floor. So I'm not really in danger in that situation just from being high up, but my brain sort of signals you should be stressed, you should be nervous. And so that's sort of a misfiring. So I'm getting a cue from my brain that there's a safety concern when in fact I'm actually safe and fine. So sometimes people need help with that from a health perspective if they have a fear, or you can see that also in social anxiety. So some people may have a fear signal, a really profound sense of anxiety and nervousness, just being around a group of people they don't know. And it feels very much like that they're in danger because they break out into a sweat, their heart's pounding, that sort of thing. So having a misfire or missignal of when to be afraid can be a difficult problem to deal with when you experience stress. Some other things that can be a problem or harms of stress can be if it causes you to kind of shut down. And usually the shutdown feeling has to do with either avoiding the situation. So you know there's something important, there's something concerning, but you get sort of frozen and you don't want to deal with it. So avoidant, or equally difficult can be if you're feeling hopeless. So when you really feel backed into a corner because of stress and you don't feel like there's solutions, you can really start to feel quite negative and have a hopeless outlook. And when we work with patients who have challenges around anxiety and depression, a lot of what we're doing is checking in with them about how they feel about the future. Because when you get in that overwhelmed, overly stressed mode, the first thing you lose is that sense of hope or that you're working towards something positive. Some of the other challenges with stress are that when you're in a state of stress, that it can be harmful when you don't have the skills you need to address the solution. So you might be encountering a problem or a situation that you've never encountered before, and you may feel like you're not able to handle it, or sometimes even ask for help. Stress can also certainly lead to a lot of conflict in relationships, where there's a lot more arguments or maybe really poor communication, and people start to withdraw. We know that stress can impact your day-to-day functioning. So ability, like for kids to do well at school, or for adults to do well taking care of their family or working. And then, of course, we know that stress is harmful when it's a situation where we're in a real life dangerous situation. So there are some kind of pros and cons to stress. And so we shouldn't be so hard on ourselves when we experience stress, but we want to think about how to get out of the situation where it's going to put us in that kind of more shutdown mode. So we want to strike a balance between the benefits of stress, which is achieving a resilience. And usually that has to do with when you're in a difficult situation, you develop new skills, you can work hard, and you can do something that helps others. And then we want to kind of minimize problems that are related to health risks from stress. And that is, we want to make sure that we're keeping good energy level, because when you're stressed, the first thing that goes is things like sleep, appetite, exercise. We want to avoid situations where we're in shutdown and we lose hope. Again, that sort of future orientation is really important when you're feeling stressed. And also, we're as humans, our nature is to need others and to interact with others. So social isolation, when it gets prolonged, can be very damaging towards our own mental health. So we want to have that balance of utilizing stressful situations to foster resilience and hopefully even growth, and minimizing the risks to our well-being. The other thing, it was mentioned that I'm a child psychiatrist. So I work with little peewees, little teenagers, and young adults, college students, as well as adults. And we know that how we manage stress across the lifespan changes, and it changes because of different factors. And any of our colleagues who are on the line who are parents or grandparents or actively involved in the life of children or teenagers know that kids, as they develop, the more that they develop skills at independence and being competent at something, that can help them to manage stress more effectively. As kids start to have more social experiences beyond their families, they can expand their support network to help solve problems and to work collaboratively. Kids and teenagers also gain a lot of experience over time that helps them to make better decisions how to manage stress. And the big antidote against stress, I know we think about the opposite of stress as relaxation, but I would make an argument for you, the big antidote for stress is to learn new skills, to develop a sense of confidence and an understanding that even when a situation can be challenging, that we have the tools to manage something or seek out the help that we need. So when we think about coping, I know there's about 1,000 different kinds of apps about coping. So there may be folks on our call here today who have done mindfulness apps, or have a Fitbit and they keep track of their sleep and their activity on it. So there's a lot of different technology-based tools that people use for maintaining resilience and healthy coping. When I work with patients, I think about coping strategies in 4 areas. And I always tell people, you can't do everything all at once. So pick an area that you want to work on, either because you want to develop some new routines and habits in that area, or an area that you feel like you've been missing out on for a while. So I'm a pretty simple thinker, and I think about things in these 4 areas. And I like to use the image of a balanced meal, because it gives you an idea that there are different kinds of coping skills and strategies that help to nourish us and help sustain us through difficult time. So on the bottom right-hand side is a cute little butterfly peanut butter sandwich. So that's our protein. And I think about the brain when I think of protein, and that is a really healthy coping strategy is to learn to build new skills. So like I said, sometimes people turn to things like mindfulness training or meditation, or learning new skills through a faith-based organization, maybe through their church, and through studying and learning about things that make them feel fulfilled and happy. But I think in general, any kind of skill building during time you're stressed, pursuing a new hobby, having something to kind of focus your attention and to feel good about things that you've done. I was reading an article recently that adult coloring books are like a new thing now, a trend, that people like to have something that they can see sort of tangibly that they've been working on, and something that they feel good about, and that feels like a good use of their time. So anything around skill building is really helpful as an antidote for stress. And we know as we get older, it's harder to learn new things sometimes. So it's also a great strategy to kind of keep that brain sharp and to try new experiences. the human brain is geared all around new experiences and learning new things. So your brain really focuses in when you're trying something different. We also have on our lunch plate over here a vegetable, and the vegetable I think about is sort of those things that maybe we don't always prioritize, but are sort of important for a healthy diet. And similarly for managing stress and for coping, I think of the vegetables, the things that help to restore and sustain us. So it's really important to reflect on sleep, appetite, activity, to really get an idea of what am I doing to help myself physically stay in good shape when I'm dealing with kind of emotional aspects of stress. And we know it's oftentimes very hard to sleep or eat regularly or have time to exercise. So thinking about picking one of those areas to work on can make a big difference when we're going through a lot of emotional stress. And then of course, there's the fun stuff in the meal, the carbs, the comfort food. And that really makes me think more about social support and connection. So one of the things that happens a lot when we're feeling stressed is we really shut down from those we love. So we may not spend as much time with friends, with family members, maybe folks we know through church or faith-based groups, or anybody at work or communities. So we want to make an effort to stay connected. And that's been really difficult for a lot of folks over the pandemic. So really figure out a way of checking in with folks and maintaining a connection is really important. And then for dessert, we have the sweetest aspect of a coping skill, which is really joy. So any kind of activity around laughing and smiling. And we know that children are really good at playing, but we lose some of that along the way as adults. And so really having an opportunity that makes you feel joyful, where you're physically laughing and smiling, is a really important coping strategy. So if you look at these 4 areas, I'm just curious if you'd like to put in the chat, which of these 4 areas do you feel like people have been kind of had the most difficulty with over the last year or so during the pandemic? So which of these coping strategies, the comfort, because of social isolation, the restorative one, the sleep, appetite, building new skills, or joy, are one of those 4 areas you think that what you've been hearing about from friends and families have been the hardest to kind of maintain or to work on? What would you say? Let me just check in the chat. I see restore, restore, restore. So pretty, wow. So pretty strong consensus over restore. So sleep, appetite, activity, those things are really tough when all your routines are gone and you don't have reasons to sometimes even leave the house to be more active in other things. So this might be a good priority for starting to reintroduce into daily life. Okay, let me move on. I wanted to make a case a little bit more for the physical effects of laughing. And I want you to think about, when is the last time that you had a very hearty, giggly laugh about something? Were you watching something on a Netflix show? Were you visiting with a cousin or a family member and they told you a funny story? Sometimes as adults, we kind of move away from the experience of laughter. And there's actually a lot of reasons why laughter is very healthy for the body and for the brain. And in fact, there are whole groups around the country of yoga strategies around laughter, where people gather together in groups and they laugh. So why is laughter physically important for our health? It actually increases your intake of oxygen-rich air. It can cause a small increase and then decrease in your heart rate and blood pressure. And that experience, that change, has a hormonal effect that's associated with a sense of relaxation. So oftentimes after you have a really hearty laugh, you have that sort of brief period after where you feel more relaxed. It can actually aid in relaxing your muscles and has a transient effect on increasing circulation. And so laughter is really important physically as well as emotionally. So even though we tend to think about when we're stressed, oh, we got to make sure we're sleeping and eating and exercising, and those things are all important, But don't forget about joy as an important strategy for improving coping. And even just watching a silly YouTube video as a family together and having a few minutes to laugh over something you enjoy can be really helpful and have good health benefits if you do it on a regular basis. So I want to shift a bit and talk a little bit about when problems with stress can lead to something that a medical professional would think about as a disorder, or something that can be evaluated and diagnosed and then treated. So these fall mainly under the categories of what's referred to as depression and anxiety disorders. And I wanted to share some points about them generally first. So depression and anxiety disorders are certainly very common. So for example, anxiety disorders, it's estimated about 30% of the population experiences some significant problems with anxiety. And depression is considered by the World Health Organization as a leading cause of worldwide disability. So, so these are really common problems that can cause really big challenges in people's day-to-day life. The other thing are these are conditions that can be diagnosed across the lifespan. And here at your medical school at University of Maryland, we actually have an infant, toddler, preschool mental health program, because we know that kids can experience, very young children can experience a lot of stress. So for example, if an infant or toddler has had a loss of a parent, or they've had a separation of a parent who's been ill and in the hospital, it may not present itself the same way as an adult, but they may be more withdrawn. They may not be feeding as well. They might be more fussy and irritable. So we actually have ways of thinking about anxiety and mood problems, even down to a very young age, in that birth to 3-year-old, based on more kind of behavioral insights about how they respond to stress in an unhealthy way sometimes. So these are conditions that occur across the lifespan. The other thing is that we know that the causes, or in medical school, we talk about the etiology. So what causes somebody to have a health problem are actually very complex. So usually people have risk factors or problems from different domains. So one would be biologic, and we think about if you have problems that run in a family, like family members who have relatives who have anxiety or depression or mood problems. So there's kind of a biologic component of risk where you can inherit that risk. But there's also a psychological or an emotional risk factor for these kind of conditions. And this can include things like, do you tend to have a more negative outlook at events that happen? Do you tend to be more blaming yourself whenever there's a problem? Do you have a tendency to more have guilty feelings? Or do you have challenges coping with stresses over time? So there can be different psychological factors. And then there's also a mode of environmental risk factors. So have you been through a frightening experience, something that was sort of traumatic that you went through? Or have you had a change in your support network where you don't feel like you have the support you need? So we don't think about the cause of depression and anxiety as just being caused by one simple thing, but rather there's sort of an interaction of risk and protective factors from those different domains. So the biologic, the more psychological, emotional, and environmental. And then the last thing I'll say about this group of disorders as a group is that unfortunately, these are conditions where they're associated with a lot of stigma, which is there's a lot of people have a negative sort of shameful feeling about sharing with others that they have this kind of diagnosis. So you might hear about parents talking about at the school bus stop. So I have a teenage daughter, and for many years, my job was, walking her to the bus stop in the morning, and we would hear about kids in our neighborhood who had asthma, or in the springtime, we heard about which kids had seasonal allergies. But we didn't hear so much about kids who were really anxious or stressed out, or teenagers with depression. And I think in part that those are the kind of conditions that we tend to be a little bit more private about. And we might have feelings of guilt or shame, or why am I feeling this way? And there are also things that you don't see physically, just observing somebody sometimes. You can't access their inner thoughts. So they may be things that are tend to be more sort of secretive and more hidden. The result of that is that there's often a long delay from when somebody has problems, significant problems with depression, anxiety, and then when they actually seek help. And we know from a lot of information in kids, especially, that that delay could be over several months and even years for getting help. So this is a condition, the more we talk about these problems as a society, the more we can kind of try to reduce some of that stigma, so we can encourage help seeking and coping strategies that are healthy for people. Excuse me. So I wanted to break these up a little bit and give you an idea about these two different categories. So I first wanted to talk about depression symptoms. And the way I think about this is, when most people use the word depressed, so if somebody says, I'm feeling depressed today, usually most of the time they're referring to their mood. And a lot of times it means that they're feeling down or stressed out or upset about something. But when a health professional uses the word depression, we mean something very different than just talking about mood. So for somebody to meet criteria for depression, you have to have difficulties in 3 or 4 different areas, and you have to have them over the same period of time. So at least a few weeks. So we're not just talking about feeling moody for a day or feeling upset about a stress in our life. You really have to have difficulty in different areas. So the first area, besides mood, is depression affects people physically. So when a health professional talks about depression as a disorder, as a clinical diagnosis, some of the criteria include people have a change in their sleep, their appetite, and their energy level. And those changes tend to be persistent. So it's most of the time, most days, for at least a few weeks. And what do I mean by a change in those things? So you can have either direction. So some people, when they're feeling upset or down about something, they sleep all the time. So maybe you've known somebody in your life where they just having trouble getting out of bed. Maybe they're missing work, or a teenager's missing school. So they're sleeping a lot more than usual. But you can also see the opposite, where somebody is staying up all night, they have a lot of negative thoughts, or maybe they're anxious about something, and they're not able to sleep as well. So for it to be a criteria when we're evaluating somebody for diagnosis as like a symptom or a problem, we want to see a change, and it has to be something that's sustained over time. So we're talking about most of the day for at least a few weeks. Okay, and so it could be increase or decrease of sleep, appetite, and your energy levels. Okay, so those are physical symptoms of depression. The second kind of symptoms are more about your thoughts, or we might refer to those as cognitive symptoms. And that is when somebody's experiencing depression, it's hard for them to make decisions. They can't concentrate as well. Their thoughts might be focused on more negative things. So might feel hopeless, guilty, or focus on death or dying. And in more extreme situations, they might even think about, is life worth living, or wanting to die, wanting to hurt themselves. So depression affects you physically, but it also affects you from your thoughts. So having change in your thoughts, both the content of your thought and your ability to focus on things like you normally would. So again, that has to be a change. And we're talking about things that are significant. So most of the time, most days, at least a few weeks. The third area where depression affects people has to do with their day-to-day functioning. And so that's either in terms of relationships. So when people are depressed, they might have more conflict in their relationships or be more withdrawn. But it also can affect their functioning at their job or at school or at home. And I will tell you something, I've been a psychiatrist for over 20 years. And when people have depression, they don't generally come to me and saying they feel sad, they feel down, they feel blue. That's not really the reason that people come to a psychiatrist. The reason they come to us is they say, you know, my wife's threatening to leave me, or I'm going to lose my job if I can't get out of bed in the morning, or I'm feeling so guilty because I'm not the parent I used to be. I feel like I'm not able to attend to my kids, focus on my kids. So usually the thing that leads people to seek help is more when it impacts their functioning and their relationships. So people, unfortunately, really spend a lot of times, they may suffer in silence because they feel bad. Their mood may be irritable, sad, or they may have like a profound loss of being able to find joy or pleasure in anything. But that's not often the reason that people come to me. So, so usually you can kind of tap into depression symptoms, mood symptoms in a back end way by first talking about what have they noticed has changed in their functioning, and then sort of asking about their mood and their thoughts. But depression as a disorder or a mental health condition, again, you have to have kind of a cluster of different types of symptoms over a period of at least a few weeks. And these are problems that don't tend to be like transient and quick and brief. These are things that people suffer with a lot of the day and on most days. So it's a little different than how most people use the word depression. Anxiety symptoms, there's some overlap with depression, but the predominant or the prevailing mood is more a feeling of being worried or tense or even fearful. The physical sensations that people have are, people tend to present with a lot of aches and pains. So these are conditions where a lot of time people present to their primary care doctor long before they come to see a psychiatrist, because they have kind of these vague problems. I've been having backache, stomach ache, and a lot of the time headache. So people tend to have a lot of physical distress when they feel anxious and worried. And some people can have a real intense kind of anxiety. What we talk about is a feeling of panic or panic attacks. And what people will describe to you there is a real intense physical anxiety where you feel like you're having a heart attack. You may break out into a sweat, your heart's beating real fast. And some people, even their hands are shaking and they feel really, really anxious. Okay. Anxiety symptoms can affect people socially. And where you see this most are if you've had something like a panic attack where you feel like you're having a heart attack and gonna die, then you start to anticipate, oh my gosh, what's going to happen if this happens again to me? So you may not want to leave the house as much. You may not want to interact with other people because you're embarrassed or worried about having that kind of anxiety feeling and not being able to leave a situation quickly. For younger kids who have anxiety, they often have difficulty separating from a parent. So this may be a child who's really reluctant to go on sleepovers or birthday parties. So even when something is fun, because they have trouble separating or being around anybody who's unfamiliar. And again, these are problems that people generally come and seek help because it's affecting their functioning. So I have patients who come to me and say, you know, I really have trouble at work. Anytime I have to talk in a group, I feel really nervous. So it's causing a lot of problems for me to be able to do my job. Or, you know, parents may say, gosh, my child at school is not doing well. They seem to know all the work and they understand it, but they freeze up whenever the teacher calls on them, or they can't get their work done because they get so overwhelmed and stressed out. So again, that impact on day-to-day functioning tends to be the kind of hook to get people engaged and to want to get help. It's really hard for people, I think, to seek help for their mood because a lot of people feel guilty about seeking help for that. Like, oh, I just have to grin and bear it. And other people have stress worse than me. So a lot of times they wait until it's impacting their day-to-day life before they come and they seek help. But this is a condition similar to depression in that you do get a lot of physical symptoms. And so it's also a great opportunity when somebody comes to see me for me to help them set up a routine physical and to check in and get good primary care and some of that preventative health screening that was mentioned in the previous class. So it can be an opportunity to talk about both sort of that connection between physical health and emotional health. So some of the concerning things where we need to sometimes think about more intensive treatments for depression or anxiety are some of these red flags. So when somebody is depressed or anxious and they have some kind of ongoing safety issue that's scary, something traumatic, then we have to go into kind of a more immediate safety planning mode. So the common ones that I hear about from people when they come in to see me, either parents bringing their child or adults coming in, are unfortunately domestic violence is very common, where there's a concern about violence in the home, or people who have a safety concern where there's an ongoing health crisis in the family and they're not worried if they're worried if somebody's going to pull through. That can be pretty traumatic for a young child. So we want to make sure that we wrap a lot of support around while the trauma is still ongoing. Sometimes people, when they're going through anxiety or problems with depression, they may turn to using alcohol or other drugs to kind of calm things down and deal with depression or anxiety. We had a speaker come and talk to college students recently, a local musician, and they talked about how they used to have a lot of stage fright, and their bandmates would always give them alcohol to drink before they performed. And so they sort of got into this mode of thinking that whenever I'm stressed, I need to drink. And it became kind of a coping strategy that ended up causing a lot of problems for them. Sometimes when people are very overwhelmed by anxiety or depression, they can have thoughts, again, where they lose focus of the future. It's really important with anxiety and depression to keep that sense of hope and future orientation. And that's where you can see self-harm behaviors and suicidality. And it might be something passive, like I wonder what would happen if I was somebody hit me with I was in a car accident and I was sort of out of this suffering. Would life be better for everybody around them? Versus people who have more active suicidality. So actively thinking about plans to harm themselves. Another thing is that when people are depressed and anxious, they express it different ways. And I've had a lot of patients through the years who can become very irritable and aggressive when they become depressed. And I think sometimes people also intentionally try to get themselves in a situation where they're going to get a fight and they'll get sort of hurt or in trouble as a way of kind of self-punishing themselves or feeling guilty. I used to work in an adolescent clinic, and I had a patient once who would deliberately, a young male patient who would deliberately provoke arguments with police officers because he thought he would get arrested or shot as a way of sort of punishing himself because he felt so miserable. People express these really intense, awful, negative feelings in different ways. So it's important to kind of explore all these different safety concerns so we make sure we put the right support in place to help people. So when we're helping folks with depression, we're not just thinking about their mood and their thoughts, but also what kind of healthy behavior is going to help them. So there's different modes of treatment for depression and anxiety, and they come in kind of 3 different categories. So one is, we believe it's really important in mental health treatment to educate people about their condition. Why is that important? Because something like depression can generally, even if you don't treat it, it's an episodic condition. So it does tend to go away over time, but it can come back. So there's an ebb and flow with some of these kind of conditions. So we want to educate them so they can identify warning signs early. And also we try to educate their family members with their permission so that they can help support and monitor their response to treatment. So we believe a successful patient is one who's informed and really knows about what are the symptoms or problems to monitor for, and so that we can check in with them so they can really give us feedback how they're responding to treatment. And then there's 2 main modalities of treatment. There's some newer things that are evolving, both through research and for patients with treatment refractory conditions, but I'm going to go over sort of the bread and butter treatments. Therapy for depression and anxiety tends to focus on thoughts, behaviors, and feelings that impact mood and anxiety. Again, we tend to think about things like anxiety or depression as mood problems, but it's very important to target not just their feelings, but also thoughts and behaviors. So the example I gave earlier, when you have somebody who can't get out of bed on time to go to work because they're so exhausted and feeling so negative and their mood is so heavy, it's oftentimes easier to develop a game plan about how to change that behavior while they're waiting for their mood to improve. So if we change the behavior and we put some support in place to help them get up on time and get to work, and we kind of reinforce that behavior, that can have a positive impact on their mood, and it also helps them maintain their functioning because they are able to maintain their job. So therapy uses all 3 of those targets to help people function better day to day. We also know that relationships are very important for mood. So we think about how to best talk through and address different conflicts, and also improve communication and problem solving. A lot of people are very ashamed of the feelings they're having, of feeling negative or depressed or even suicidal. And so they don't share that with important people in their life, their significant other, their family members. So teaching them how to communicate about those kind of challenges can really bring a lot of support back into their life. We also practice new approaches to managing stress. So we do relaxation, deep breathing. A lot of people are interested in mindfulness right now. And then we think about therapy as working best when there's a somewhat consistent schedule, trying to meet weekly or every other week, and people can decide what format they feel the best about. Some people prefer doing one-on-one individual work, but we also do family work, and sometimes group work can be very helpful. In addition to that, there's a whole class of medication options that we refer to as antidepressant medicines. And antidepressant medicines, the way I would think about them, they're kind of the opposite of headache medicine. So if you have a headache, you take maybe some Tylenol, some Advil, sleep it off, you feel better. And then usually you don't need to take it right away. Maybe you wait until the next headache comes back or something like that. But with antidepressant medicines, you're feeling lousy. You have all these symptoms, the physical, the emotional, the cognitive, or the thought symptoms. You take a medicine and you don't feel better right away. And then it builds up over time in your system. And so usually after about 4 weeks, you can see about half of the benefit of the medication, but it takes up to 6 to 8 weeks to feel the full benefit of it. So they don't kick in like a light switch kind of thing. It's not like a headache medicine. The other thing about it is that these medicines, they kind of help, it's sort of counterintuitive. People take them when they're feeling better. And that's because they can help with those depression feelings coming back. Because again, depression is an episodic condition. So that's why people take this as a more maintenance medication. And we'll often, for a first episode of depression, talk to people about taking it for at least 6 to 9 months if it works well for them. And then people can kind of make a decision if they want to continue with more long-term treatment for maintenance. The other thing is that these are medicines where there's a lot of options of what to do. And people, unfortunately, there's a significant group of people who don't respond to the first thing that you try. So it's important to remember for antidepressant treatment, there's always a plan B, plan C, plan D. So there's lots of different medications that we can try, and people respond differently to medicines. And then sometimes for people who aren't responding well to first-line treatment, we kind of think about using a combination and using 2 medicines that might work better together. So there's a lot of options. That's the main thing to stress, that this is a nice thing to treat as a physician because there's a lot of options. So I'm going to end with a couple comments, and then we could just dive into any questions. Tips on help seeking. It's really important when you're feeling depressed or anxious to not wait to get help. And usually the fastest way in to get help is to utilize supports that already exist. So if you have a contact with a primary care provider, that could be a good first start to have a conversation. If it's a younger child, starting with the school counselor, even the teacher can be a good place to start. And a lot of large employer groups, companies have employee assistance programs, and a lot of those are free programs where you can go meet with somebody for 2 or 3 sessions, and they'll help you decide, help you get connected with resources. The other thing is to know your safety net, and I'll provide some resource information about that. These are things like crisis support. So everybody benefits from having a hotline number in their phone, just if you're not sure what to do or how serious something is. Being aware of programs support folks with domestic violence concerns. Those are really common things that we encounter when dealing with depression or anxiety, and knowing where to go for your local urgent care emergency room. We also think, in addition to traditional health treatment, peer support can be very helpful, and I'll give a couple examples of that. Peer support are for folks who have lived experience, either having one of these conditions or a close family member, or being a parent to somebody who has one of these conditions. They can often offer a lot of practical support and emotional support about what it's like to go through a situation like that with a loved one. And then we think a lot about safety planning. Again, when you're depressed, your thought process change. Remember, it affects you cognitively. So if you lose that future orientation, you just want to make sure that there's nothing nearby that they can impulsively use to harm themselves. So this is when we want to be mindful about any access to weapons in the home, any extra medication, and is the person getting isolated? So we want to make sure we're really planning out to offer the support, monitoring, and kind of safety that folks need. So some of the mental health resources are Maryland 211 is kind of one-stop shopping. You can call there around housing crises, food insecurity. Do you not have enough food to feed your family? Are you a veteran and you've had some difficulties related to your military service? Are you having a mental health crisis? Are you suicidal? So 211 is sort of a universal program for one-stop shopping. If you forget where to call, you can try that as a starting point. National Alliance on the Mental Illness Maryland, so NAMI, and the Maryland Coalition are peer support programs. So those are really great resources to help folks who may be family members, relatives of somebody who's dealing with one of those mental health conditions. House of Ruth is a great resource for both legal aid and also to talk through crisis aid for folks who experience domestic violence. And then finally, we have the national SAMHSA. So the federal government has a suicide hotline. That's a great resource. And this is a number, just put it in your phone. Put it in there because you never know when you're going to encounter somebody who's hopeless and you don't want like at 10 o'clock at night to start Googling resources and figure it out. Just put it in your phone and share it with family members. It's a great resource to spread amongst your network. So I'm going to end there. I had in there an opportunity to either ask a question, but also this is an opportunity to brag a little bit and reflect. So when we think about stress, we think about it in a negative way, but there's probably a ton of things you've done really well for yourself, for family members over the pandemic, or things that you're grateful for. So it's sort of our final message that we can't eliminate stress completely, but we can balance out how we think about it and also give ourselves credit for using stress as a time for growth. So I'm going to end there and welcome if anybody wants to ask a question in the chat or if you'd like to go off mute. So it looks like there's the number for the suicide hotline again. Let me leave that on the screen. And that's 1-800-273-8255. If you forget about it, just Google suicide hotline, and it's usually the first hit you have on Google. But just having that number in your phone is a great resource to have. Let me see other questions or comments. If a person does have depression and anxiety and have medicine and have therapy, but family members does not understand the member. Okay, so do you want to unmute? It looks like DeMario Payne, just so I understand the question. Is it more about like if other people don't really connect with what they're going through or they're having trouble understanding?
For me, because I have depression and anxiety, and I think family members don't understand what I go through for a day-to-day basis. Some days I have good days, some days I have bad days. So it's just like my mind goes wild. So I just don't think they understand. Is there like support for family members who don't really understand?
Thank you so much for sharing that experience. And that's a really important point that you're bringing up. It's hard for people who maybe even care a lot about a loved one who's going through depression or anxiety. Sometimes they don't understand, they don't know what to say. And then that misses out an opportunity for people to connect and support one another. So that might be a situation where a peer support group could be really helpful. I would encourage you to check out the website for NAMI Maryland, NAMI, as a resource for folks who may be dealing with a child with special mental health needs, adolescent, teenager, college student. Maryland Coalition of Families is a great place to start because they offer support groups and programs that really help improve that family communication. The other thing is, as a therapist or a physician, I really encourage people to bring in family members to sessions because remember that illness education, we need a village to kind of help us to monitor when we have a safety concern and also to support others. So I think it's terrific when somebody wants to bring somebody into a treatment session, and I always welcome that because it's an opportunity to provide information and to give people tips on how to communicate. I think a lot of family members really want to do right by somebody going through these problems, but they just don't know how to talk about it or bring it up, and they feel uncomfortable, like they don't want to say the wrong thing. So thank you so much for asking that question. I'm just scanning through the chat to see, write this down. So that's I think the 1-800 number. I found a hard time until I found seniorplanet.org. There's a class called Morning Stretch on Monday through Friday at 10 a.m. This class addressed all four. It's an amazing community with meditation, stretching, and discussions on everything. Thank you so much to Miss Sherry for sharing that information. So a lot of people put the word restore as the one that we're missing. And so that sounds like a great opportunity. Thank you for sharing that resource. I'll pass that on to other people as well. Did you want to unmute Sherry and comment about it?
Wait a minute. Oh yeah. I actually went through post-traumatic stress myself with my boyfriend had a motorcycle accident in 2010.
Oh,
6
my
months
goodness.
later, my mother had a stroke, and 6 months after that, my brother-in-law had open heart surgery. And in 2015, he finally passed away after being in hospital for all that time. And then my mother passed away in 2019, and my brother-in-law passed away with COVID in 2020. So I had a lot of baggage to deal with, but I read a lot. And when my boyfriend and my mother had strokes, actually, that's one of the reasons I ended up with, well, I went to University of Maryland mini med school, which is this, and that helped me so much because I learned so much about it. And I also got some books out on it. And I read this one book that actually described me, because when you have post-traumatic stress, it affects the part of your brain that's like a primitive part of your brain that you feel afraid all the time. I had intense fear that I just couldn't understand. I was afraid to do my bills. I was afraid to walk out of the house. I mean, I still functioned, but it was really hard. I had to push through it. And so I actually got a really good book that explained everything. And I'm in a different place now. I feel like 100%. I just, I every time I would get near an ambulance or a motorcycle, I would start crying. It was just a reaction. I couldn't help it. And then I decided, well, I mean, after reading several books, I sat with it. And whenever that would happen, I'd pull off the side of the road and I sit there and say, wait a minute, he's not in the ambulance. It's just a response that you have. Like if somebody pokes their finger towards your eye, you're going to blink. It's the same thing with that. Whenever there was something there to trigger me, I would have that response. But in sitting with it and realizing that happened then, it will never happen again because he's gone. He's not going to, be in another accident. I'm dealing with things like that. I just actually got to a point where I saw some kids, they were on motorbikes without helmets, zigzagging across the road in front of me. I always end up with stuff like that, which normally would have had me like totally have a meltdown. And I was just so mad at them for being careless with their lives. But then I realized that, wow, I didn't have a meltdown.
Yeah.
And I also, that class saved my life because with my brother-in-law having COVID, my niece had come up from Virginia and stay with me. So we were, closed in for 2 weeks. And then I went to her house for 5 months. And all of those, all that closed in and everything else, it's like going to that class, they're so interesting, the people. I like diversity. There's all races. We had people from Alberta, Canada, people from Paris, France.
Yeah.
It's like all over the world that come to these classes. The other day, somebody said, I think we should
Can I just interrupt for a second? Because I don't want to lose
Sure.
my thought. I wanted to commend you on a couple real specific things you did that were great examples of what we talked about. So first of all, I want to say I'm very sorry for those difficult experiences you've been through. And I think that's very typical in life. Things don't space themselves out evenly. And I think a lot of us relate to that experience of having 2 or 3 bad things happen around the same time. But I wanted to highlight some things you did really well in terms of healthy response to stress. One is you developed new skills. So you made an effort to learn and developing new skills and having a sense that I have the competence and the ability to manage something is really, really important when you're feeling stressed and overwhelmed. The second thing is that you allowed yourself to kind of retrain your thoughts so you're not blaming yourself for everything. So what I heard from you saying is, this is because of these experiences I went through. So you gave yourself a healthy framework rather than one that's sort of blaming of yourself. And it sounds like you were able to be somewhat patient with yourself as you're going through that. So those are two really great things. And then the third is you started to think more about not just the sort of overwhelmed here and now, but how you're progressing and improving, and that sort of gives you a trajectory to think about the future. So you did a lot of really terrific things in how you responded to that. So thank you.
Well,
for
another
sharing
thing,
that. It's really
another
inspiring.
thing, oh, I'm sorry.
Oh, go ahead.
I was going to say another thing is that I visualized about when I was younger and I was really happy and everything else. How do I get back there? You know what I mean? I put that in my thoughts. I tried to have something to look forward to, because there was a time right after his accident that I really didn't even want to be here. It was harder to be alive than it was to be gone, but I couldn't do anything like that because I have kids and things like that. But it was really difficult to be here.
Yeah.
And, I feel sorry for people that don't see that, what is so overwhelming right on this day, it will be different later on and you'll be able to deal with it. But like when it happens right away, you might not be able to, but you can in the future, because it will resolve itself somehow.
Yeah.
But you have
Thank
to
you
be
so
able
much.
to.
I really appreciate your sharing that. I just noticing the time. I know I need to pause
Yeah,
to give
got it,
people a
okay.
break, but thank you. I really feel inspired by that. And I thank everyone who put in a resource or response to the chat. Please know it's fine to share my slides with anybody who was here today, or to pass them on. I included my email address. Please feel free to reach out if I could be helpful. If there's a resource that you need, this pandemic, we have to all support each other, and we're all colleagues now. So please reach out if I could be helpful to you. But please know that stress is a balancing act. Don't be so hard on yourself. Try to come up with kind of a healthy, at least, ratio, and continue growing and learning as you're doing through this course. So thank you so much, everyone, for your time and your attention and all your great ideas. Thank you.
Thank you.
So I'm going to stop sharing my screen.
Okay.
And Miss Lauren, we're all good?
Yes, we're all good to go. Thank you very much for joining us this evening. I know we thoroughly enjoyed your presentation and we appreciate your expertise. So just thank you for being with us.
Thank you. Thank you so much, everyone. And I just want to say, Miss Galloway, I'm sorry I couldn't hear your voice and speak, but I know you had some great ideas. Please feel free to reach out to me by email. I'm happy to learn from anybody from the group. So thank you, everybody. I really enjoyed spending time with you tonight.
Awesome. Thank you. Well, everyone, we're going to soon transition to taking a quick break. We want to try to stick to our time limit. So we're due to start our next session at 7:05. So if we can take a quick 3 to 4 minute break, this is a great time to use the restroom, grab some water, stretch your legs a little bit. We will resume in about 3 to 4 minutes.
Welcome back, everybody. I know there was a very short break. We'll now hear from our second presenter for the evening, Dr. Dominic Williams. Dr. Williams is a clinical instructor at the School of Medicine within the Emergency Medicine Department. He sees patients at both the University of Maryland Medical Center and the nearby Mercy Medical Center. Dr. Williams received his medical degree from Lake Erie College of Osteopathic Medicine, Bradenton, and received his training in emergency medicine here at the University of Maryland. He's held several positions in resident and medical student leadership and is currently a faculty development fellow. Dr. Williams' interests within emergency medicine include psychiatry and teaching procedural skills. Please keep in mind that Dr. Williams will be taking questions during the last 5 to 10 minutes of his presentation. Be sure to insert your questions in the chat box while the presentation is in session. And here to provide instruction on the treatment of minor burns, bruises, and cuts, Dr. Dominic Williams.
Thank you so much. It's a pleasure to be here, and I'm so excited to be able to spend a little bit of my evening with you all. Let me just get my Google set up here nicely so we can all see exactly what I'd like to talk about this evening, and we can go from there. Marvelous. So I'm going to start sharing my screen. Fantastic. So I took a little creative license with the title, and I think that we're going to have what is an incredibly beneficial evening, mostly because when it comes to looking after injuries such as, burns, cuts, bruises, and so forth, the first few minutes of that situation will be vital in changing the outcome of that situation if it's a serious injury, but also in predicting the success of the treatment, whether it's even a very minor injury. So let's get started with a little project on blood, sweat, and tears. First of all, whenever you lecture academically, you have to give all your disclosures. So here's my nice empty room of disclosures. However, on a lighter-hearted note, I'm performing this lecture from home, so I have several noisy children in the rooms below, and one dog who doesn't understand what Zoom is or how important it is, and a couple of cats that might also try and feature in tonight's presentation. However, in the spirit of community, they're all here to help us, so if they do get involved, I trust you'll forgive me. Our objectives for this evening are to define the different types of wounds that you might come across in your daily life, to discuss the treatment options for those wounds, and also to determine the best location. Not everything can be handled at grandma's kitchen sink. Sometimes you need to go to the urgent care center, and other times you might need to go to the emergency department. And I hope that after the end of today's lecture, you're going to be pretty informed about what choices you're making for your loved ones, or people you happen to come across. And there's a little more on that later. I do have a warning. By the very nature of what I do, I have grown somewhat accustomed to seeing fairly horrific things and not feeling overwhelmed by them. It's years of training and kind of learning how to adapt to those kind of situations. I'm sure many of you are also very experienced in your area of expertise. And so there are some injuries here this evening that are pretty miserable and definitely require a lot of attention, work. And I hope you'll forgive me if they make any of you nauseous. Hopefully there's you'll have some time to kind of get to grips with that. So if you ever should see one in real life, you'll be able to assist with the issue. So when someone comes to you and says, I've cut myself, particularly I'll give my children as an example, it can often be something as perhaps insignificant or very painful as a paper cut, but it can also be something as devastating as a wound to the hand that causes life-changing circumstances for the rest of the individual's life. And so somewhere along the spectrum here, if I've cut myself and there's a paper cut, to I need to go immediately to the best hand surgeon around for reconstruction of my body, there's a kind of spectrum of disease or a spectrum of problems that we might face. In fact, there's 4 major types of injury I want to talk about when it comes to insults to your skin, or as we're going to refer to it in the mini medical school as perhaps our dermis, or the barrier to the body's invasion by various things, whether it be heat or bacteria. There are abrasions, there are lacerations, puncture injuries, and avulsions. And they are all similar in the sense that they have all broken your skin, but they have very definitive treatments and management techniques that you will learn a little bit about this evening. First off, abrasions. I think all of us have gone through our lives and experienced these, whether it be as a kid running forwards and scraping our knees and having our parents pointed out to us, or having embarrassingly falling over at work and scraping it on something, or maybe even as you brush up against a wall, you might experience an abrasion. An abrasion is very much a scrape of the upper layer of skin, and is something that we see on a daily basis. We'll talk about how best to manage abrasions, because most of these wounds are managed in the same set of 5 steps, which we'll discuss later on. The importance of abrasions is that they can often be very dirty. So if you have the opportunity to clean them, and the patient that you see is willing to have them cleaned by you, we'll talk about the best ways to do that moving forward. From abrasions, we move to lacerations. Now, all of us have cut ourselves. Maybe all of us have experienced stitches or staples, but some of us have got through life without having this. And a laceration normally occurs from a sharp object. As we age, it can be a blunter object as our skin integrity is lost somewhat. But lacerations often require closure, as they've broken all the way through the top layer of the skin, the epidermis, and they will need to be approximated, which is the medical term for brought together, so that they can heal in the best possible way. Moving on from lacerations, we talk about punctures, and thankfully my experience with puncture wounds is more walking around Legos around our home than it is on thumbtacks. But a puncture wound often breaks the skin in a very small area and goes quite deep into the skin, which is where it can cause problems. The nature of what has punctured you is what can cause the most difficulties. For example, if you happen to be visiting one of Maryland's lovely beaches and get caught on an oyster shell, or be eating at one of our restaurants and have the same issue, it's the chance of bacteria being on that object that punctured you is significantly higher, and therefore somewhat more dangerous in terms of management of this situation. Next, we have an avulsion. Now, an avulsion is like a scrape, but instead of taking the top layer, it took an entire chunk of skin off of the patient. And an avulsion can look quite horrific because it rolls up in the top layer of skin, which was covering this entire area, but now is exposed. And I purposefully picked pictures that didn't have quite the number of pixels that would intimidate too many people, so that we can see the basis of the injury without nauseating too many of our colleagues this evening. So from avulsions, so just to recap again, we have abrasions, lacerations, punctures, and avulsions. We will talk about burns later, but they're in a slightly different category, and you'll see why. One thing I do have a passion about in terms of emergency medicine is talking about the number of psychiatric patients that we see on a daily basis. It's been estimated that between 10 and 20% of patients presenting to the emergency department have psychiatric issues that require attention from an emergency physician, if nothing else, to pass on the resources like were discussed earlier by Dr. Greaves, such as the suicide hotline or resources for counseling. If you see an injury pattern like this on an individual, normally a teenager, and typically female, but not always, you'll notice that there's a small pattern of linear lacerations that are so small, they probably don't deserve closure by any particular means, but are enough of a cry for help that I would recommend starting a conversation with that individual. It's been demonstrated time and time again that people that come to the emergency department or see me because of hurting themselves or making attempts to hurt themselves are actually crying out for someone to talk to them, whether it be a family member, a school friend, a colleague, before anything actually happens in terms of an attempt on their life. So this, as we're talking about wound care and small lacerations, this is an example of how we can have an impact on our community by being willing to start a conversation. There's no judgment here. There's no insult. It's simply being willing to start to talk to our our community around us about what is going on in their lives, that they are using cutting themselves as a coping mechanism. Just as was mentioned earlier, not all our coping mechanisms are healthy, and this is certainly one that we can redirect in a more productive and a more useful manner, so to speak. So always notice the type of injury patterns. All right, 1 second, my side. There we go. So when it comes to choosing where to go, there are urgent cares and there are emergency departments. Urgent cares are often equipped with very basic wound care, which means that if your wound is something that you look at and you think, I don't know that this is going to need stitches, I don't think this is going to need staples, I don't think there's anything going on underneath this wound, then we can probably go to the urgent care. And as I was saying earlier, wounds occur on a spectrum of disease. If you think about scraping your knee, you didn't need to go to the hospital. But if you think about, and I hate to use this as an example, but it's the best one, if a motorcyclist comes off their motorcycle and has road rash along their body, that's an abrasion that requires going to the hospital to be cleaned and cared for and covered up in the best, most appropriate manner. And so again, whether it be a small laceration or a puncture wound, you need to decide whether you're going to go to the urgent care or the emergency department. And if you're not sure, what you're equipped to do by the end of today will be to call and ask, where's the most appropriate place to go? Now, obviously, if the injuries seem so severe that you've called 911, they're going to make that decision for you and you're headed to the emergency department. However, if you have the time, you're able to pick up the phone and describe the injury and get the best care in the best location for each member of your community. So a few factors to consider. The very young and the very old are far more likely to have complications regarding their wounds. And therefore, I would recommend that if you have a younger patient that you think may require closure of their wound, or an older patient that may require more in-depth management, that you would lean towards advising them to go to the emergency department. Now, none of you would thankfully have to protect your license after taking your mini medical school here in terms of your decision-making, but I would recommend that when you have either end of the age spectrum, that you would urge them to seek a higher level of care, and it's that way you're urging them on the side of safety, and I think that's best for these age groups in particular. So when we talk to the patient, I know it may seem like us as physicians sometimes are too quick to talk and not quick enough to listen, but the first thing we should be encouraged to do is to speak to either you as the person with the patient or the patient themselves and find out exactly what happened. Was this a fall that happened in the home on a piece of carpet, or was it out in the street on a pile of trash? What time did this happen? Was this something that happened yesterday and now finally you noticed that your child's pants were covered in blood and they needed to be evaluated? Or was this something that happened immediately prior to arrival? Is there any medical problems that the patient has? And is there something that you need to consider? Are they going to heal well? Is their skin good quality so that it's going to be easily closed? Is there something that we have to worry about in terms of scarring that the patient needs to be addressed in a particular way? Another important question is whether or not the patient has had a tetanus shot, and the tetanus vaccine and immunoglobulin is exceedingly effective in preventing what is otherwise a catastrophic infection that can lead to death in non-vaccinated patients. So because of that, we always ask, and the joke in emergency medicine is if you don't remember when the last time you got your tetanus shot is, the answer is today. So they will need an up-to-date vaccine because it's such a potent infection that it will lead to a brutal death of tetany, which is essentially muscle spasm. And so if we can prevent that in just one patient by giving however many vaccines, it's worth doing. We also want to talk about associated symptoms. Now, if I cut my wrist, which is going to be awkward here, if I cut my wrist and I've injured the structures beneath it, then I have to worry about the fact that now I can't feel my fingers anymore. Now I can't move my fingers anymore. And this is a cut that is much more serious than just being able to close the top and pretend everything underneath is okay. And we're going to talk about that when we talk about our stages of dealing with wounds. The other thing that the physician should do, or you should do when you get to see these wounds, is to look and see if there's any damage to our underlying tissue. Is it just the top piece of skin that came off? And if so, is there anything underneath that's now exposed and we're concerned about? Is there any part of the wound that is now gray or dusky because of the fact that we haven't been able, it's now lacking oxygen because the blood vessels have been cut off to that area? Is there wood, dirt, trash, seawater, anything now sitting in the wound that's now festering inside of it? And is there any element of numbness? So when we say neurovascular and we examine a patient, what we mean is, are the nerves all working properly, and are all the blood vessels all doing their job and perfusing, which means helping make our skin the nice warm temperature it should be, and our nice normal color. The next thing we need to do or to discuss when we're looking at the wound, after we've listened and looked, we need to wash it. When we talk about washing a wound, it used to be that in the emergency department, you'd be told, oh, we need to use our special water. It's got to be these big bottles of special sterile water. Or it's got to be this big bottle of saline. Well, we did a lot of studies on that, and we looked into it, and it turns out that tap water works just fine. And if you clean enough of the wound, you will actually, it's better to run the wound under the tap. If I have a patient that's cut their hand, I encourage them to run it under the tap because I can use significantly more volume. In fact, as emergency medicine doctors, we say that the solution to pollution is dilution. So if you're worried that you have a dirty wound, you want to wash it. So if you have a first aid kit with a tiny little bottle of saline, thinking this is the best thing for it, it turns out that the data shows that the best thing to do is to find the sink, put the hand over the sink, and hold it there for a couple of minutes while you clean out the wound. Now, it's always very important to recognize that you may not have got everything. And even as a physician, if I put my spectacles on and I'm staring at this wound and I say, I think I've got as much as I can, because you never know. Sometimes when things get tucked up underneath, you need to be able to explore the wound. And we'll talk about why that's so important later on in terms of infection or being able to close it properly. So if I was going to give a takeaway tip for this, irrigation is best done with the sink. You don't need to buy expensive bottles of saline or sterile water. Your tap water is effective, or your faucet, sorry, forgive my my accent, is effective and should be used to clean out most of these wounds. The next thing that you won't have at home, but you will have in the emergency department, is anesthesia. So if you have someone that is unlikely to be able to tolerate you washing their wound, that should be a trigger for you to tell them to go somewhere else other than your home to get the wound taken care of. So we use a substance called lidocaine, and in lidocaine, it feels like a bee sting going in, but then essentially numbs the area. I'm sure many of you have had cuts and bruises or cuts fixed before. Some of you may have had things like nerve blocks done for dental pain. Or dental procedures, and the lidocaine is in that family of medications, and it numbs up the area and allows us to clean it out more deeply, which is and to explore the wound, which is one of the benefits of being at a place such as a hospital where we have access to those medications. For a fun fact, if you ever hear about lidocaine with epinephrine, that means that we've added epinephrine to this lidocaine, and it makes the lidocaine stay in the same place for longer because it shut down the blood vessels around the area. So that might be a little bit beyond the scope of this talk, but it's really, really good to know that if you come to a hospital, we can numb up that area. Particularly useful if I have a dirty wound in a child or someone that's almost inconsolable, to be able to make them comfortable before we start cleaning their wound is incredibly important. The next thing I want to talk about is exploration. And that's not so much going on this hike where you might actually get injured. It's looking through the wound itself. Now, if I cut, again, I'll use my wrist as an example. If I cut my wrist and the skin is broken, I need to be able to look all the way through my wrist's injury and to see if there's any blood vessels that have been hurt, any nerves that have been hurt, and any tendons or ligaments that have been damaged. Tendons in particular are very important as they provide connection from our muscles, which allow us to move. So you can have a simple cut on your finger that is now, if you're a pianist, has rendered you unable to do your job, because when we found a cut, all we did was close up the cut and we didn't look underneath it. So if you have a cut that happens on a finger or over a joint, or where there are ligaments and tendons involved, it's very important that we assess that area. And that's why the advantage of coming to an urgent care or potentially a hospital is that when in emergency medicine, we talk about looking through these injuries in a bloodless field. What that means is that we make sure we've cleaned it out, stopped the bleeding, which is an important part we'll talk about later, and we can look all the way through the range of motion. So you could fix this finger at home. You could put a piece of tape on it and pretend that the cut is fine. But if the cut went deep and now this person can't move their finger to help them function in their day-by-day business, we haven't done them any favors by fixing the cut on the outside. And so it's really important to be able to consider this, these injuries. And as you go out into your communities and share some of this wisdom, I hope that taking the extra moment to have a look and see, hey, does he actually feel this? Can he feel it properly? Can he bend this finger at this joint? Can he move his arm here? That's really, really important information to be able to know when you're deciding whether or not to seek further medical attention. So exploration is the other key word I want you to remember. And if you ever come and see one of us at the emergency department, we should always be looking at the wound and how well you can move this hand, wrist, extremity injury. The next thing we want to talk about is closure. Now, human minds like to close things. If any of you stare at the screen long enough, you'll see that this is not just a random pattern of dots. You'll close the outline in your mind and you'll notice that it's a Dalmatian. Now, when we talk about closure for wounds, there's several ways that we can bring things together. And most of these are not available to you at your home. So if there's a cut that you think is beyond the epidermis, that's that very outer layer of skin, and a cut that's bigger than bigger than your pinky finger, you need to really strongly consider coming into the emergency department or the urgent care to have a more thorough evaluation of that wound. Now, when we talk about closure, there's a few different things. I'm sure all of you are familiar with steri strips, and you can buy them at Walgreens, and they get in a mess sticking them on, and then they come off real easy because you forgot that you had them on, and then wash your hands. So these are a useful way to close wounds. In fact, we'll often do steri strips in combination with glue. Now, you can get glue at also Walgreens as well, but I would not recommend actually trying to close wounds yourselves with these substances unless you have taken a little more training on this. These are the options that I want you to be aware of that will happen when you get to an urgent care or an emergency department. Now, steri strips you can definitely attempt, and if it's an area of your arm that is not under high tension and the cut closes naturally by itself and you cleaned it out and you're very confident there's no wound underneath, absolutely, by all means, go ahead and close this with steri strips. If this is a clean injury, the chances of it getting infected are considerably very low, less than 1 in 100. So I think that when you keep an eye on that wound, and you can follow up with your primary care doctor or go to an urgent care if you're concerned it is getting infected, then I think it's very reasonable to take that course of action. Because I want to say, especially, I completed a lot of my training in the United States. It's a big deal to come to the emergency department sometimes. It's a long wait. It can be loud, uncomfortable. You need childcare for your other people, especially now with COVID. You go and you're alone. Like it's a big decision to come and get extra care. But if the wound is concerning to you, I'd recommend taking that step and letting us take a look at it so that we can help you and help those around you. So the other options you may have seen are staples, and these we typically in the emergency department anyway would use for wounds in your hairline. As that is well hidden and the scalp is very thick. So it's a great place to use staples. For those of you that have had surgery, you probably have had staples on some of your wounds and then have them removed at different times after your surgery, depending if the wound was under tension or not. Typically, if we have staples in your head, you should come back to the emergency department after 7 to 10 days, and we'll reevaluate whether they're ready to come out. You can also do that at your primary care. I would not recommend YouTubing how to take them out yourself, partly because when you go to the physician to have them taken out, they will reassess the wound for you and make sure that they don't think there's a deep pocket of infection or anything concerning going on there. And then finally, the classic suture, which is where we need to sew your wound together. We'll use this often on areas for multi-layer closure, which means that if you cut yourself in several deep areas, then we can close this either in the operating room, or if necessary, we can do it in the emergency department as well. And there are lots of different types of suture that we spend a long time learning about, and every different place that you get fixed up on your body has a different number of days that it takes for it to heal before we remove those sutures. And again, we recommend that you come back to the place that placed the sutures to get them removed. There's part of that is because we know the wound typically better at that point, but also there is insurance reasons, and it tends to save the patient money. So that's one of the reasons we recommend that for wound checks, you come back to the same department. I can't guarantee that. I'm not in charge of all insurance companies, but it's worth checking into to make sure that you're getting the best care you can for the most appropriate price. Now, the other thing we've already talked about is tetanus, but I want to bring it to your attention again. I would like each one of you to know next time you go to the hospital when your last tetanus shot was. If not, next time you go to the hospital for a wound, that tetanus shot should happen that day. Tetanus is a preventable, horrific way of ending someone's life. So let's all take the responsibility to make sure that we are aware of our tetanus shots, and we'll get them if we need them when the time comes. Now, next is antibiotics. If you're concerned that your wound is so dirty and so worrisome that you might need antibiotics, you should probably not be dealing with it at home. And I think that's fairly self-explanatory. Now, the reason we give antibiotics is often kind of prophylactic or preventative for some of these wounds. But often if we've cleaned the wound or been able to clean the wound as the best possible way with significant amount of fluid, then actually you'll find that most of these wounds will not get infected. In particular, wounds on the face, on the scalp are very vascular and have really good blood supply. So any infectious material there, the body takes care of it very swiftly. However, if you have certain comorbidities, if you have diabetes, if you have a wound in an area that's not got great blood supply, or if you have a wound that was definitely dirty, like a bite wound, we would absolutely need antibiotics. Again, human bites from whatever activities someone might have been engaging in. If any of you have teenagers at home and maybe have got into some rough and tumble, and they have what's known as a fight bite injury, that injury has to be very well cleaned, and it has to go to the urgent care or the emergency department for antibiotics, because humans carry bacteria in their mouths that can cause horrific infections, and it's very important that we treat those. Same for cat bites and for dog bites. It's very important that those kind of injuries go on antibiotics. So when we're thinking about that, it's very important for us to at least see you in urgent care, even if the wound itself is not bad, because you're going to need antibiotics to prevent an infection. That said, if you come and see us and we do all the things by the book, the data says that 1 in 200 wounds will actually get infected. So it's important to take that follow-up appointment and to at least have someone monitoring the wound to see if it's becoming hot, so warm to the touch, to see if it's swollen, significantly more painful, right? These are the things we need to look for in wounds. If there's any new drainage, or if the wound is opening up, we need to be able to revisit that wound and look at it again. Okay. So there are always going to be specialists around, and there's reasons to go and see a specialist. We all have, children in our lives. When my kid gets, themselves falls and cuts their head open, we want to make sure that someone that knows what they're doing is touching their head and face. I want to encourage you that all of us at the emergency department have extensive training in doing this. But if there are certain wounds, like around your eye, that should definitely have attention paid to them, as there's so many little structures in there, whether it be tear ducts, or glands, that need to be paid attention to when those wounds are healing, that we often would recommend getting specialists involved. The others are cuts over joints. Joints are very easy to get infected, and if an infected joint occurs, then you end up in the hospital for several days, and that's not what anybody wants. Also, wounds to the genitals, no matter how they happen, how embarrassing it might be, they need to go and see a physician, or to an urgent care team, or at the very least, and most likely to a emergency department with follow-up with urology or obstetrics and gynecology, depending on the gender. So it's also important that if you are aware of one of these, I want you guys as members in your community to think about those, if they happen to children, whether or not these children are in a safe environment and what steps we might need to take to ensure that everybody is okay there. Now, this is, you know, something that's kind of tragic to have to talk about, but I'd rather start a conversation about this and have you thinking about those things than regretting never having thought about those things. So when we see children and we see their injury patterns, we want to think about, you know, was this something that happened accidentally, or is this something that we need to step in and maybe make sure that the child is okay? In Maryland, as physicians, we're mandatory reporters. So if those cross our mind, we have to talk up to about those, and occasionally we have to take it to the next step, and always within the spirit of trying to protect the patient, and especially when they're an at-risk member of our community, whether they be very young, very old. So moving forward with this, bruising is something that we always see. If we see bruising that is beginning to swell and swell, and becomes to the point where we can't move the joint anymore, I would recommend getting that evaluated, potentially because it can be an indicator that more significant damage is underneath. Now, a lot of us have had pretty severe bruises, I'm sure, throughout our lives, and healed quite wonderfully with a beautiful rainbow of colors as the small blood vessels begin to repair themselves, and the blood that has spilled out into that area breaks down and goes through the different colors of the breakdown. I want to talk about a special case for each of the 4 types of wounds. If you remember, we talked about 4 types of wounds. The first is abrasions, then we had lacerations, then we had punctures, and then finally we had avulsions. Now, the most important, or one of the examples I want to talk about is ligature marks. Now, ligature marks, as we all know, are marks from around our neck, from an injury that has caused tension around our neck. Now, the reason this is important is because if you ever see this on someone, even if it happened by accident or if it happened as a part of a suicide attempt that they're trying to hide, they must be evaluated in an emergency department. And I want to empower each one of you today to make that call and give that input, because when you have an injury around the throat that has caused a mark like this, you can actually have internal structural damage, whether it be to the trachea, that's the air pipe that carries air from our mouth to our lungs, or to the blood vessels around. In fact, some of these injuries can cause strokes in even young people later on in their life, and they need to be evaluated at a hospital to make sure that there's no injury underneath these marks. We've already talked about this one because it's so important, so I want to remind you again. If you have a laceration that crosses into structures, not just on the fleshy part of your arm, if you have a laceration that crosses into structures, I want you to clean it, I want you to stop the bleeding, and I want you to get to the hospital where it can be evaluated and explored properly to make sure that they have full function of their finger, if that's possible, after this injury. This is also a very interesting topic. This is kind of a terrifying injury. If there's high pressure injuries of injections, so grease is a common one. If someone gets grease injected into their finger, it can actually travel all the way up into their arm and need surgery to debride or to cut away all the affected tissue all the way up to the top of their arm. So if you have anyone that you know that has a high pressure injury, it can be a paint sprayer or a grease sprayer, and it goes into your finger, I want you to encourage them to go to the hospital straight away. This needs evaluation and it needs help, because they need to be monitored, and all that needs to be cleaned out. And it's much better to do it up front before it becomes necrotic or broken down or dead, than it is to do it after you've waited for several days. This can, as you can see in the middle here, this can cause complete death to the tip of a finger, even to a hand. There's some pretty horrific pictures that I didn't put in, you're welcome, of injuries that can happen this way. So in particular, if you have paint or grease, these can cause horrific infections and breakdown of skin. And then finally, special bruising. This is called a Morel-Lavallée lesion, and that's something you don't need to remember. But if you have, it's an injury that is essentially a special degloving. So you remember you can have skin peel back. Well, that can happen inside your body and not be obvious on the outside. So if you have an injury where you rub up against something very, very hard, maybe in a car crash, and you have this swelling area under the skin. I need you to pay special attention to that, because if it's getting larger and larger and growing, that's because there's a huge amount of blood collecting in this area. And this can cause what's called compartment syndrome, which means that the pressure in the little compartments of your body actually becomes greater than the pressure of the blood vessels supplying that area of the body. So when that happens, that can kill that area of your leg and result in it dying slowly and painfully, and it's a miserable experience for the patient. So we actually measure these pressures, and if necessary, we have to take these patients to the operating room to prevent them from happening. So these 4 scenarios are things that I want you to think about. If in your communities you see these injuries, you might save a life by helping to encourage someone to go to the emergency department rather than to stay at home. And then bandaging is a technique that you all have practiced. This is something that I would encourage each one of you to have at home to help with controlling the bleed, which is something we'll talk about momentarily. This is the first steps that you're going to take at home to make sure that you can help someone by them getting to the emergency department and getting them the help they need. There are thousands of different bandaging techniques, and if you have a wound that you think is actually treatable at home after you've cleaned it and put a little ointment on it and close it up for the next 24 hours to let it sit before you're washing it and cleaning it twice a day. You can Google any one of these techniques, and that's fine to learn it on the fly as you go. If you spent time now to discuss each one of these, you will not remember a single one of them. So I want to encourage you that if you look up the best way to bandage something, you want it to be able to stay firmly without cutting off any circulation below the injury. You want to be able to make sure that the bleeding is controlled and that the patient is comfortable. So these are a variety of techniques that we use in the emergency department, whether it be to support a wound or to completely, to make a sling for a patient that's had their arm as well. So things I would recommend that you have in your toolkit at home as a first aid practitioner, if you choose to pursue that, or just to help with basic wound care. First of all, gloves. I have to highlight that as a lot in the sense that we want to protect one another. And I want you to make sure that you're staying safe while you're helping others. Other things to include here, gauze pads that I want you to put on top of all the wounds, and then bandages that I want you to wrap around the wounds. We all have, I trust, running water at home, and that is going to be your best cleaning agent. Soap and water are as effective as all the expensive things that they will sell at Walgreens or CVS or any other pharmacy. So I want you to make use of those and to use those to clean. It wouldn't be fair of me to talk to the community. I also work at shock trauma as part of my training, and we see a lot of bleeding injuries. And 35% of victims die due to severe bleeding before they get to the hospital. So I want to take a moment to have a serious conversation about how we can help learn to stop the bleed. And if we can stop the bleed, this is a national movement, but it's particularly near and dear to those of us that work in Baltimore and deal with so much of the violence that occurs here. This is something that really needs to be a part of our lives within the community. So I would recommend taking this course if you have the opportunity to. It's run by practitioners out of shock trauma. They are starting to do them again. And if you go to the university website and look for Stop the Bleed, you can actually find a course that can help you learn to do the following things. First of all, you've got to make sure that you take care of yourself, and then you will try to stop the bleed of the victim that you have found. If it's on an extremity, it's quite easy to tie something around the extremity and to put direct pressure on a wound. And then you're obviously going to ask somebody to call 911 to help with the assessment of this wound. But ultimately, the class will teach you to apply a tourniquet, which is something that I cannot teach you probably in the time we have this evening, but it is something that will impact your community and can save the lives of those around you if someone has been shot or stabbed or severely cut by this injury. If it's on the central region of the body, you need to be able to pack the wound with whatever clean materials you have available to help try and stop the bleed. Stopping the bleed is maybe the most important thing that we can do as community members trying to help those around us if we see a devastating injury in front of our eyes or around us while we're in our communities. I want to take a couple of minutes to talk about burns. Burns are a very serious injury. There are many types of burns. Most of the ones we'll deal with are at homes are from fires, thermal burns from liquids being spilled on us. And at this time of year, we can actually deal with frostbite in our homeless population, which actually is a hypothermic burn. And so we need to learn how to take care of that. Thankfully, I don't see much in terms of chemical burns, radiation burns, or even lightning strikes, which is a whole nother part of burns. However, all of these should probably be evaluated at a hospital unless it's a very small scald or a first-degree burn, which just involves this slight top layer. Anything more severe than a sunburn should be seen at a hospital, and that's the takeaway point from this. And if you're sunburned and it's all over your body and has affected your entire and it's affected you systemically, is the word we use, then that should probably be evaluated as well, at least kept a close eye on by a primary care doctor. But wounds that affect the epidermis and dermis and go all the way down, as you see here, where the blood vessels are, where the nerve endings are exceedingly painful. And then the third-degree burns actually become painless at the center of their burns because they've burned away all the nerve endings, which is pretty catastrophic in terms of healing as well. There's ways to assess how much you've been burned, but the best way to do it, if you're a community person and you want to know roughly how much the patient has been burned, is to take their hand, and each hand represents 1% of their body surface area. And that's how you can tell how much of your family member or your loved one has been burned, and how you can communicate that to 911 when you call them or to the doctor when you see them. These are some facts about when to transfer patients to a burn center so that you understand there's a lot of criteria. You don't need to memorize them. You don't even need to know them, but there's a lot of reasons to go to a specialist burn center because burns are very dangerous and can have a lot of complications, including infection, dehydration. We lose a lot of fluid if our skin is not intact. And so there's a high chance that if it's a significant burn, you're going to be told to get transferred to the burn specialist where they will protect you and care for you the best possible way. Again, if you have a very small burn, the best thing you could do is cool it down and clean it off. So we want to cool water and we want soap at the very to clean off the area. Washing our wounds is, again, the most important thing that we can do to help prevent infection. And then if you are going to treat the burn at home, I would recommend a dressing that is a non-stick dressing. If you have Vaseline in your home, this is a clean tub of Vaseline is a fantastic way to dress a burn if you are heading to the urgent care or emergency department for further evaluation and treatment. That way, when you put the dressing on, it won't stick. And so when we peel it off to have a look at it, it won't cause more damage. That's a really important take-home point for today, that if you're going to bring a burn to the emergency department, don't just use the clean cloth like you would for bleeding. Put something that's non-stick on top of it. Vaseline is a great thing that most people have around the home. Put that on some gauze, then put that on top. And that way you won't cause more damage when you're trying to cover up the burn. So I think that brings us almost to the end of our talk. I would love to have some time for questions if anyone has any questions. I know it's been a whirlwind. If I wanted you to take away anything from this talk, it would be clean the area, stop the bleed, and know what your limits are, because there's nothing worse than trying to deal with something without the resources that you need. Don't be as afraid to ask for help. And if you come to an emergency department and we see that it's a wound that it shouldn't take too long to care for, then we will obviously prioritize that as getting something that we can send you home as swiftly as possible. But the consequences of wounds that get infected or get mismanaged can be life-changing, and I wouldn't want that for anyone here or any of the loved ones of anyone here. So thank you so much for your time. You can feel free to email me with any questions. I know it's a significant amount of information. It'll be in your handouts as well, and I can type some of it up if you want some more basic reference guides. But I highly recommend that everyone here signs up for the Stop the Bleed course when it's available. And I just want to empower each one of you to really make those choices and give the advice that you've learned this evening to help those in your community. So thanks so much for your time. I really appreciate it.
And Dr. Williams, it looks like there's a question in the chat for you.
Okay.
Lead by
Oh,
Ms.
what are the
Carr.
4 types of injury? So the 4 types of injury, you have abrasions, which are like scrapes. You have lacerations, which are cuts. You have punctures, which are like stabbing injuries. And you have avulsions, which are like tearing off a flap of skin. I've had staples in my head in the year 2004, and I didn't have to go. Okay, all right, yeah, okay. I tell my family that tap water is good enough to drink too. Sometimes, yep, it should be good enough to drink. There are obviously areas of the country that it's not the best drinking water, but I agree. If they release information every year, we get it in the mail. You know, the water testing that they do. If you're good enough to drink, it should be good enough to wash out those wounds. Especially as this is water that's running through it. It's not going to stay there forever. And the solution to pollution is dilution. Any other questions, comments? I'd be happy to talk more.
If there are any more questions, feel free to unmute yourself and shout them out. We would hate to end the session without giving you the opportunity. Maybe if you're trying to type your message in the chat and just want to go ahead and unmute yourself, feel free.
I do have a quick question.
Sure.
Thank you so much for this information. It was very useful. My question is more so like, when would you go to urgent care versus the EMS, you know, the emergency at the hospital? Like what's the, when I say urgent care, I'm talking about more like you're a patient first, if you will.
So it's always a difficult question, right? So most emergency departments will have a fast track area where even if you go to the emergency room and you're worried that you need to go there, and then they look at it and they're like, oh, no, actually, this is probably going to be okay. There should be a fast track area that they can get you in and out relatively quickly. The advantage of patient first is perhaps due to the wait times and maybe even lower costs. I will say that, right? These are kind of practical logistical things. When we go to the emergency department, and each wound is different, so you can have a laceration that some urgent cares will feel comfortable taking care of, right? Which is why I would go back to, if you're not sure, call them, because if the patient first you're going to is going to look at your cut and say, yeah, that needs stitches, we don't have any here, that'll be $200. You've wasted your time, money, and energy. So call them and ask them, say, hey, do you have the capability to sew up these wounds? Do you have x-ray if I'm worried there's a foreign body in there and I need to get some imaging? Like, what do they have available to you? So that's important. And ultimately, a lot of urgent cares will refer you onto the emergency department if they feel uncomfortable taking care of your wound. But if you have, even for a moment, thinking, hey, might be a little bit more complicated, or this might mean that later on I need to see a specialist, like anything that involves joints, anything that involves like vital areas of your body should probably be seen at a hospital, purely because not only after they've been closed properly, they'll be able to get follow-up for you. So if you have a hand injury, you really need to follow up with a hand surgeon to make sure that you can still play the guitar or you can still do your job, because nothing is worse than getting a simple injury and having something missed that then impacts your life further on down the road. I know that, I'm sure we can all think of loved one. I remember my grandfather had a finger that didn't work ever quite the same because it didn't get set quite right when he broke it as a kid. And we have a lot more available to us these days, and so it behooves us to take advantage of it when we can. And I think the emergency room has just a little more in terms of resources than some of the urgent cares. Does that answer your question? I know I basically just said it always depends, but that's kind of the truth.
No, that helps, because I wouldn't even have thought to actually call the urgent care before going to say, hey, look, do you have, you know what I mean? I wouldn't have never thought to do that. So it was very helpful. Thank you for your presentation, and thank you for your answers.
Of course. You're welcome. Can you address what to do if the bone breaks through the skin with a wound? Yes, absolutely. You should be at the emergency department. You should get antibiotics. And if a bone is broken through the skin, that is 9 times out of 10 an open fracture until proven otherwise. And most of those will go to the operating room for a washout. So whether it's on your hand, your elbow, or any other area, that that should definitely be addressed at the hospital.
All right. Awesome. Wonderful. Well, if there aren't any more questions, we just wanted to take a minute to thank you, Dr. Williams, for your time and for your expertise. I'm sure many of us can walk away with a lot of really good tips to use in our everyday lives when it comes to caring for our minor injuries. So we just wanted to say thank you for spending this evening with us. We greatly appreciate you.
Thank you so much. It's a pleasure.
Wonderful. And also a special thank you to Dr. Reeves as well, who joined us earlier this evening for her session on anxiety and depression. So this concludes our second week, week 2 of Mini Med School. Let's turn our attention to our screens for 1 minute. Next week, we will be joined by 2 esteemed faculty members. Dr. Justin Price will be presenting on chronic pain management, and Dr. Emerson Wickwire will share useful information on almost everything you'll ever need to know about sleep. So you want to be sure to be here next week and log in on time. We have 2 other great sessions that we are preparing for next week, so you definitely don't want to miss it. And also, please remember to complete your individual course evaluations. The link is in the chat box. I made sure to post that during our break. So if you scroll up in the chat box, you will see the link to our week 2 evaluation. So please take a moment to complete that after today's presentation. All right, wonderful. Well, thank you everyone for your time. We enjoyed having you this evening, and we look forward to seeing you next week. Have a great night.
Thank you so much. Have a good one.
Thank you.